With that, everyone, welcome to our live webcast, ATTR Wild-Type Cardiac Amyloidosis, often overlooked, not uncommon, and manageable. Thank you for joining us. My name is Mike, and I will be the operator for our presentation today. Now, before we get started, I would like to take a moment to acquaint you with a few features of this web event technology. At any time, you may adjust your audio using any computer volume settings that you may have. As part of our opening comments today, there are just a couple of interactive polling questions that we'd like you to take a moment to respond to. And the way you can respond to these questions is click on the radio button that best represents how your attendee site feels about our first question and read out loud to get an idea of who's participating in our webinar. If you would, please choose the response that best fits you at this point. So if we can just take a moment and have you make a response to that, that would be very appreciative, and we'll give everyone just a couple of seconds here to come up with their final response to our first interactive polling question. And again, we do appreciate your responses to this polling question. Looks as if the majority of the sites have made their selection. So at this point, we'd like to go ahead and just move forward. We do have another additional question that we'd like you to respond to. And that question also will read as follows. If possible, if you are a patient, what type of amyloidosis do you have? Is it AL, ATTR, wild type, AA, or other? If you would take a moment again to just go ahead and respond to our second interactive polling question, giving us an idea of what type of amyloidosis you may have. As we give you a moment or two to respond to that polling question, on the right-hand side of your screen, you see the text chat window. It's a large window which holds all of your sent messages. There's a smaller text box at the bottom where you can type in your questions. To send in a question, click in the text box and type your text. When you're finished, click the send button. All questions that you submit are only seen by today's presenters, and your questions will be responded to in the order in which they were received, will be addressed at the conclusion of our presentation today. We also want to remind you that today's presentation will be recorded, and it will also be posted on the Amyloidosis website for you to review, or if you know people who were planning to attend today and are not able to make it, they would have an opportunity to then review the content at that time once it is posted on the Amyloidosis website. In addition to that, at the conclusion of today's program, we ask that you complete a brief post-event survey, if you would. That survey will help us at the Amyloidosis Foundation plan future web events. So again, if you would take a moment to complete that at the end of the presentation today, we would very much appreciate that. We are joined today by our speaker, Dr. Mat Maurer, who is the Arnold and Arlene Goldstein Professor of Cardiology and Professor of Medicine at Columbia University Medical Center. Dr. Maurer is a general internist and geriatric cardiologist with advanced training in heart failure and cardiac transplantation. He has received grants from the National Institute on Aging to study cardiovascular changes in older patients and specializes in the care of patients with heart failure and a preserved ejection fraction, including patients with amyloidosis. Dr. Maurer also directs the Clinical Cardiovascular Research Laboratory for the Elderly, that's CCRLE, at the Allen Hospital in New York-Presbyterian Hospital. So with that having all been said at this point, we'd like to go ahead and begin today's presentation and turn things over to Dr. Maurer to begin. So Dr. Maurer, welcome, and begin when you're ready.
This is Dr. Mat Maurer from Columbia University. I'm thrilled to be here today to talk to you about a condition called wild-type transthyretin cardiac amyloidosis. For disclosures, it should be noted that I do, and my university has relationships with several pharmaceutical companies and the government who actively supports our research efforts. And I today will discuss some novel and investigational products to treat TTR cardiac amyloidosis. Now, as background, systemic amyloidosis is a group of disorders that are characterized by an extracellular deposition of a fibrillar protein. Deposits of the amyloid fibrils in an organ progressively interfere with the structure and function of the affected organ. In this case, the focus today is on the heart, but can affect other organs throughout the body. There are more than 24 proteins known to form amyloid fibrils inside humans. But I like to joke, especially because cardiologists are not very bright, we only really need to know about two predominant proteins that form amyloid in the heart. One, which is not the focus of today's discussion, is AL, so-called light chain cardiac amyloidosis, that is associated with an underlying plasma cell dyscrasia, and transthyretin amyloidosis, often abbreviated as ATTR, which occurs in two forms, one due to mutation in the transthyretin gene, and another form that is again the focus of today's discussion, the so-called wild-type form, in which the protein has no mutations, but is normal, i.e. is the type of protein that exists in the wild, hence the name wild-type TTR cardiac amyloidosis. So what is cardiac amyloidosis? The term amyloid refers to, as I mentioned, protein deposits. The protein deposits have a structure that likes starch, hence the name amyloidosis, and they tend to bind to a particular a component that we use for diagnosis called Congo red. Amyloids are essentially aggregates of these proteins. They fold into a particular shape, and many of the copies of these proteins stick together, forming the fibrils that unfortunately disrupt the structure and the function of the heart. As I mentioned, in the heart, two main types, light chain amyloidosis and transthyretin, which both have a mutant and wild type form. Unfortunately, amyloid is a disease or disorder that can mimic many other common cardiovascular and other medical problems, and so it's been recognized over the years that there is a significant risk of misdiagnosis or delayed diagnosis. That is a particular problem for many patients. Also, the naming of amyloid is often confusing to not only patients, their loved ones, caregivers, but also providers. The nomenclature involves letters such as AL, ATTR, or AA, for example. The first letter A always stands for amyloid, and the subsequent letters after A stand for the protein that is causing the deposits in the various organs. So AL would stand for amyloidosis due to light chain. ATTR would be amyloidosis due to transthyretin, and we would abbreviate it ATTRM for a mutation, or ATTRWT for the wild type form. AFIB stands for fibrinogen. There's ones due to ApoA1 or lysosome, and AA, a form of amyloid attributable to a chronic underlying inflammatory condition. Again, today's focus is on the transthyretin or wild type form. These are data that colleagues have collected at the Amyloid Research Consortium, essentially delineating in a cohort of about over 200 patients the misdiagnosis that was unfortunately led to delayed diagnosis in individuals with amyloidosis. And as you can see, misdiagnoses or delayed diagnosis affect lots of different providers, cardiologists, general practitioners, internists, nephrologists, hematologists, and neurologists. In this same study, researchers delineated the delays in diagnosis reported by either patients, caregivers, or other loved ones. And as you can see, for both AL, cardiac amyloid, shown on the left, and for ATTR, cardiac amyloid, shown on the right, a large percentage of the patients for AL, often they saw more than 5 providers before a diagnosis was made, and for TTR, similarly, patients were seeing 3, 4, or 5 providers prior to a diagnosis being made. In AL, because it's a systemic disease, many different providers made the final diagnosis, including cardiologists, hematologists, nephrologists, whereas for TTR, because it's predominantly cardiac-centric, a majority of the patients who were diagnosed had were seen, I should say, by a cardiologist who made the final diagnosis. I wanted to spend a little time talking about the production of proteins in general in the body so that one can understand how this disease, amyloidosis, develops. I'll now just show you briefly a video of how proteins are produced in the body. So protein synthesis is an important part of sustaining life. Here is a cell, and inside the cell there's a nucleus, and you can see the DNA here. Our genetic code has been unzipped and uncoiled, and we are now transcribing essentially the DNA. The messenger RNA shown in red has been made. It is now transported outside of the cell into a portion of the cell called a transfer RNA, in which now the mRNA is being read and proteins are being produced via individual amino acids. So every 3 letters of our genetic code indicates which of the 20 amino acids we should be producing, and as time passages, we've now essentially completed making a full protein. To indicate that the full protein is completed, there is something called a stop codon that tells the cell the protein production is finished. This is the quote-unquote primary structure of a protein that we make. We make billions of proteins in our body. Everything in our body is composed of proteins, and it's quite abundant. In fact, the only thing more abundant than proteins in the body is water. So proteins must be converted from their primary structure into folded structures in order to do their job. And unbelievably, a simple protein has about a trillion different ways it can configure or fold. And so it's quite a testament to human biology that proteins fold in the right way and that we don't see more amyloidosis. Shown in this video here are individual amino acids, the 20 of which that form the primary structure of a normal protein. This indicates which amino acids are occurring in which direction. Subsequently, proteins then fold to form what we call their secondary structure. As you can see in this particular protein, there's a coil called an alpha helix, and there's a beta pleated sheet in which the protein folds on itself. Proteins that have a lot of beta pleated sheet often become amyloidogenic because they can fold on themselves. The tertiary structure of a protein is shown here, in which it folds, and the quaternary structure is how one protein interacts with others. Transthyretin is actually a protein that has a quaternary structure in which 4 individual molecules form together like a 4-leaf clover, and that's important for its appropriate function. So if you, in this video, envision what could happen to a misfolded protein. Here we have a protein. It is attempting to formulate its normal, if you will, tertiary structure. It's trying to get into the right shape. But if the tail end, shown over here, this loop is misfolded and doesn't form its normal structure, it can subsequently aggregate or line up with other proteins that have a similar shape and structure. And when these proteins line up, they quickly form the amyloid fibrils that can get stuck in organs such as the heart. Hopefully this illustrated the normal process of protein production and how protein should fold and how protein misfolding can occur, which is the important underlying biological basis for transthyretin wild-type amyloidosis. Protein misfolding has been appreciated, just so you understand, as not only a cause of amyloid disease, but a cause of many other age-related conditions, including Alzheimer's disease, Parkinson's, cystic fibrosis, and even sickle cell anemia that affects younger individuals. So this is a common mechanism to many important disorders. Wild-type transthyretin amyloidosis has had various names over the years, and that sometimes leads to confusion. I mentioned why it's called the wild-type form because the protein is normal, and it's usually abbreviated as ATTR wild-type or WT. It's also been called in the past senile cardiac amyloid because patients who experience this condition are often older adults. It's been in the past also called senile systemic amyloidosis, in which there's some recognition that while the protein predominantly affects the heart, it can affect other organs, including the GI tract, the ligaments, and bony structures. And the more commonly used term, probably not as derogatory, is age-related cardiac amyloid, describing the fact that this condition rarely affects anyone under the age of 55 or 60 years of age. Cardiac amyloidosis is thought to be a relatively rare condition, which is why many providers never consider the diagnosis in their differential. Certainly, AL amyloid, which is not the focal point of today's discussion, is, I would describe, a very rare disease. It has a incidence of about 10 people per million. So if there are 300 million people living in the United States, there are probably 3,000 or some odd new cases every year, maybe 4 or 5, and about half of patients with AL amyloid have cardiac involvement. So there are relatively few people with this particular condition, that is AL amyloid, so we would consider that to be rare. Transthyretin amyloidosis due to a mutation is more common than AL. It affects individuals in the United States who are predominantly of African American or Irish descent. The reason is that African Americans commonly carry a mutation in their TTR gene that leads to this disease. In fact, it's estimated that between 3 and 4% of African Americans at birth have a mutation called the VAL122-ILE mutation. The VAL122-ILE means that at the 122nd position of the protein, isoleucine replaces valine, one amino acid substitutes for another. This probably affects upwards of 50 or 100,000 individuals in the U.S. who are elderly and of African American descent. There is a common mutation in individuals of Irish descent, which is called THR60ALA, in which alanine replaces threonine at the 60th position of the protein, which also affects individuals with mutant transthyretin amyloidosis in the U.S. So I would consider this to be not so rare. But today's discussion is really focused on the wild-type form of the disease, what we used to call senile cardiac amyloid, or SCA abbreviation. And it's estimated that with the aging of the population and the recognition that the fastest growing segment of the population in the United States and worldwide are actually people over the age of 85 years of age, that this condition could affect upwards of 1 million individuals in the United States. So I would argue that this is not rare at all and important. At Columbia University, in our cardiac amyloid program, we've seen over 400 individuals with a cardiac amyloidosis, and this is the distribution of the types of amyloid that we've seen to date. As you can see, there's an equal distribution of AL and a wild-type TTR, with the transthyretin form due to mutations being less common. This pie chart, however, does not, I think, really explain what's happening over time, and so that's shown here. And if we divide our experience into an early, middle, and late, as you can see, the patients who are diagnosed with wild-type TTR amyloid now in the last few years accounts for more than half of all of the subjects that we're seeing. And again, it's my assumption that with the aging of the population, that a transthyretin wild-type cardiac amyloidosis will become the most common form of systemic amyloidosis that clinicians care for. Those data are supported by a recent large registry. That registry is called TAUS. It stands for the Transthyretin Amyloid Outcome Survey. It's a database of patients who are diagnosed throughout the world with transthyretin amyloid. There are almost 4,000 individuals in this database who have participated and agreed to have their information de-identified and shared so that researchers can learn more about the disease. And in the United States, at last look, there were 390 patients with a transthyretin amyloid, and you can see the distribution here. 48% of those patients had the wild-type form of the disease. The form that affects African Americans, I mentioned, 23%, and ALA60, the form that affects those of Irish descent, 11%. These individuals are typically older adult males, about 76 years of age. The gender disparity in the diagnosis is interesting and maybe something we can talk about in the Q&A. These individuals usually have increased wall thickness. This is the septal thickness of the heart, which is normally 12 millimeters or less, and in this case is 18 millimeters. and their pumping function of the heart, the so-called ejection fraction, which is normally preserved over 50, is present in these patients, where normal is about usually over 55. But their hearts are pumping a reasonable amount of blood. The problem with the heart is it's thick and leathery and can't expand or fill very easily. And in this data set, again, historical survival was not so great at about more than half the people alive at about 3 years. Other researchers have begun to investigate, again, how common wild-type TTR cardiac amyloid is. This is a picture that shows the distribution of patients at an average hospital, Columbia or somewhere else, who are admitted to the hospital with heart failure. And as you can see, shown on the x-axis here is the ejection fraction. In green are the people who have a normal pumping function of the heart, 55 or above. In red are people who have a ejection fraction between 40 and 55. And in people who have a reduced ejection fraction, they're shown in blue. And researchers in Europe took this cohort in green, who were consecutively admitted to their hospital, and they leveraged an emerging non-invasive test, which we'll talk about a little bit further, called the technetium pyrophosphate scan, or in Europe, the DPD scan, which can non-invasively identify cardiac amyloid due to the transthyretin type. And they scanned all of these individuals consecutively. Here's a patient who has a normal scan. As you can see, the scan shows increased uptake in the sternum or the bone and a little bit of uptake in the ribs, but there's no uptake where the heart would be, as I'm showing here, where here's a patient who has a positive scan, and you can see the outline of the heart pretty clearly, indicating that there's marked uptake of this substance, technetium, in the heart, which is highly specific for transthyretin cardiac amyloid. And they found, unbelievably, that of this large cohort of people who were admitted to the hospital, about 15% had transthyretin cardiac amyloid, all of whom had the wild type form. So could be a really important cause of heart failure in what we say is a preserved ejection fraction, abbreviated as HFpEF. What are the common symptoms that patients report when they have wild-type TTR amyloid? Well, fatigue is universally present. They talk about effort intolerance and an inability to walk far distances or even short distances at times and do the things they want to do. They complain of shortness of breath, sometimes called by physicians or other providers dyspnea on exertion. They complain of chest fullness or chest discomfort. Some people even say they have chest pain. There's often abdominal bloating because the heart is not pumping well and blood is backing up, in this case into the liver and the abdomen, so there could be even fluid in the belly. They have a swelling in their legs, and some people lose consciousness, pass out, which medically is talked about as syncope, that's the term. Often individuals have trouble sleeping. They require more and more pillows to prop their head up, or they sleep on a wedge. The medical term for that is orthopnea. Some patients rapidly need to get up in the middle of the night because of shortness of breath, and doctors call that PND, which stands for paroxysmal, which means abrupt onset, nocturnal, nighttime dyspnea, shortness of breath, abbreviated PND. There's often a lot of urination at night because blood is now circulating a little bit better, and many people complain of what's called nocturia, urinating at night. And patients may not pass out, but they could complain of dizziness, lightheadedness, or irregular or abnormal heartbeats or palpitations. We've learned over the years that transthyretin, this protein, exists like a four-leaf clover. This is a cartoon that I've drawn. Each one of the transthyretin proteins links together with three other transthyretins to form its normal four-leaf-like clover structure. And either mutations in the protein or aging causes this normal quaternary structure that I pointed out before in the videos to not be existing and the protein to fall apart. And one of the pieces doesn't have the right shape. It misfolds, and these pieces line up and they form the amyloid fibrils. This cartoon can be replaced by a much more elegant picture from the Kelly laboratory, in which here we depict in green, red, blue, and yellow the actual transthyretin protein Again, existing like a four-leaf clover. Each one of these, red, green, yellow, blue, is a single transthyretin, but they link together to form the normal four-leaf-like structure. If the protein is misfolded, it will not exist in its normal four-leaf structure. The misfolded pieces, or what we call monomers, agglomerate together and form the amyloid fibrils, and that is the pathology or pathogenesis of the condition. So transthyretin amyloid, as shown here, and how the disease develops is due, as I just described, to misfolded pieces of the protein. When it deposits, just so you know, in the nerves, not the focus of today's discussion, we call that transthyretin amyloid polyneuropathy. This is a disease that usually affects individuals who are 30 to 40 years of age, often in some European countries such as Sweden and Portugal. Often people in Japan are affected. There are patients in the United States who also have this condition. It's due to genetic mutations in which the amyloid deposits in the nerves. What we're talking about today is amyloid depositing in the heart, and we would call that TTR amyloid cardiomyopathy or ATTR cardiac amyloid, and this affects individuals who are usually, as I said, over the age of 60, and to date at least predominantly seems to affect men more than women. So if we try to distinguish transthyretin amyloidosis due to a mutation versus transthyretin amyloidosis due to the wild-type form, as I mentioned, the wild-type form is predominantly a disease of older adults, where the form due to mutations has a variable, what we call penetrance, can show up when you're 30, 40, or 50, and it's highly dependent upon the particular mutation. This particular condition to date has been described in relatively equal number of men and women, whereas wild-type TTR has a predominance, at least to date, being diagnosed in men. To date, again, predominantly individuals seen at large centers are of Caucasian ancestry, and the predominant organ affected in wild-type TTR, distinct from mutant TTR, is the heart, whereas the heart can be affected in mutant TTR, but more often the nerves are affected, initially causing a neuropathy. So we in the amyloid world like to educate other providers, and we always say to them, in order to diagnose it, you have to think about it. And so these are some clues that we inform providers about, and you may reflect on your own care and see if any of these were relevant. Many patients with cardiac amyloid have heart failure with a preserved ejection fraction, as I mentioned, but the most common reason to have heart failure with a preserved EF is to have long-standing high blood pressure. And patients with amyloid usually present with heart failure or preserved ejection fraction, but a normal blood pressure. That's one of the clinical clues when their blood pressure is previously high and now well controlled. We think of amyloid in that circumstance. Because amyloid affects both the left and right side of the heart, many conditions like coronary artery disease may just affect a small area of the heart and cause a heart attack, not both sides, but amyloid does affect both sides. The patients with amyloid often present with right-sided heart failure, an enlarged liver, ascites, which means fluid in the belly, and edema or swelling in the legs. Patients with amyloid usually do not like standard heart failure medications, including what we call ACE inhibitors or angiotensin-converting enzyme inhibitors or beta blockers. So that's also a clue. When your provider is treating you with standard medicines and you don't feel well, that's often an indication of the underlying disease. And many patients have a history of orthopedic issues, either bilateral history of carpal tunnel syndrome, lumbar spinal stenosis, or a history of a hip or knee replacement. And when doctors begin to think about it, they often order tests. There are imaging clues. They can look at the EKG. EKGs tell us the electrical signal from the heart, and because amyloid is infiltrating the heart muscle, the electrical signal tends to decline over time, so the voltage or electrical signal becomes low, but the heart is becoming thicker. And that's because it's being replaced, or being infiltrated, I should say, by the amyloid protein. So the voltage is low, but the thickness is high. This is so-called the voltage to mass ratio. I'll show you a picture in a few moments, I believe, of an MRI, which can diagnose or lead one to suspect amyloid because there's what we call diffuse delayed enhancement or scarring of the heart muscle. There's a particular pattern on echo that this is ultrasound of the heart that causes a sparing of the apex or tip of the heart. I'll show you. And what's really changed the field is these non-invasive scans that I mentioned at the beginning that rely on nuclear scintigraphy. In the United States, we call this the PYP scan. So here is a MRI of a patient with a cardiac amyloidosis. This is the heart shown here in cross-section like a donut, and you may not appreciate it, but this heart muscle in the black here is very thickened. The heart is squeezing reasonably well, and so this is an increase in the mass of the heart or thickness. And down below, these are short axis slices, again, pictures of the heart, in which normally the heart muscle looks very dark or black like it does up here, and the blood inside the heart looks very white. In this circumstance, you can see the heart and the blood look both kind of grayish, and this enhancement or indicates scarring in the heart muscle, which is highly suggestive of cardiac amyloidosis. It's not diagnostic, but highly suggestive, and MRI has been a way in which clinicians have realized that a patient does have cardiac amyloidosis. This is a form of echocardiography shown here that you may have had or get at some point in time. This particular type of echocardiography is using something called strain, in which the heart muscle, which is all the way over here, you can see, is labeled with little dots, and what we're measuring is the change in the distance between each of these little dots throughout the heart muscle. So this is the main pumping chamber of the heart, the left ventricle. This right here is the mitral valve that you can see flinging open, and this is the left atrium, and this is the right side of the heart. And we call this the base, and we call this here the tip of the heart or the apex. And you can see from the color coding that the tip of the heart is moving very well, and so the strain or movement is very good, nearly -20. But the base of the heart, the bottom of the heart here, is not moving very well, and so that has poor strain. This particular pattern in which the tip is moving well and the base is not is highly suggestive of all forms of cardiac amyloidosis. If you were to take this picture here and kind of like a can of Coca-Cola, squish it downward, you would see the tip here in the middle, and you'd see the rest of the heart kind of all around, and you can see here that the tip of the heart, demonstrated in this picture, is red or moving much better than the bottom or base of the heart, and this has been abbreviated by some clinicians as called a cherry on top, like an ice cream sundae, in which the strain is preserved at the tip. The standard way that we used to have to make a diagnosis of transthyretin and cardiac amyloidosis was to do an invasive but relatively safe procedure called an endomyocardial biopsy, in which a small tube would be inserted into a vein in the groin or into the neck, and the tube would have what we call a bioptome. On one handle would be literally a scissor handle, and on the other would be a little jaw that can open and close, go up against the heart muscle as shown here, and take a small little piece out that could be evaluated under the microscope to see if amyloid was present. Obviously, this is a test that has certain limitations. It is relatively safe, but there are some risks. It can only be performed at specialized centers, and it requires some technical expertise not only to perform it, but to analyze the information. And so we believe the need for an endomyocardial biopsy is what contributed to a lack of awareness about wild-type transthyretin amyloid over the years. More recently, as I mentioned at the beginning, there have been newer techniques to diagnose transthyretin cardiac amyloidosis. This is a seminal report by a colleague, Claudio Rapezzi, who is in Italy, who did what we call bone scans on individuals. This is an individual here, A and B, who do not have amyloidosis, and C and D do. You can see here's the patient's face and skull, their chest, their legs. And in both of these patients, you can see that there's no uptake of the tracer in the heart, which is pretty clearly shown here in panel C and in panel D. You can easily identify in the middle of both of these patients' chests that this isotope in Europe called DBD, D, in the U.S. called PYP, similar isotopes but slightly different chemically. They have a high avidity, or they like to stick on amyloid due to the transthyretin type. And so they can be leveraged to non-invasively make this particular diagnosis. We've used similar techniques in the U.S., and these are data that we published a few years ago, in which up here is a patient who does not on top have cardiac amyloid, and down here is a patient who does, transthyretin form. Again, these isotopes are pretty specific for the bone, and so you can see there's increased uptake in the sternum in this individual with no uptake where the heart would be, whereas in the patient down below there's marked uptake in the myocardium or heart. And we developed a quantitative approach in which you draw a circle over the heart and you ask the computer to count how much of the substance is in the circle, in this case 32. You draw a circle in the other side where the heart is not, and you ask it to count how much is in here, only 16. And if you divide 32 by 16, you get a heart to contralateral, contralateral meaning the opposite side ratio of 2. And we showed that anything above 1.5 was highly sensitive and highly specific for distinguishing AL and transthyretin amyloidosis. So how do we advocate people approach a patient who they suspect has cardiac amyloid? We advocate that providers always have a heightened suspicion for this diagnosis. It's not as rare as everyone thought. It can be managed effectively, and as I'll show you, there are lots of emerging treatment options. So again, you got to think of it to diagnose it. Typically an older adult with some features, low voltage on the EKG, a thick-walled heart, or the MRI. We advise that providers counsel the patient that they're going to explore in their bodies, through a non-invasive process, hopefully, whether they have this condition and what it would mean, so they're informed. And the key here in this approach is to rule out a different form of amyloid that we didn't talk about today, but extensively, I should say, called AL or light chain amyloid. That can be evaluated for at least the substrate for it with some blood tests. Why is it important to evaluate for this form? Because this form is treatable with certain forms of chemotherapy and is treated very differently than transthyretin amyloid. If someone has evidence of proteins in their bloodstream that could be consistent with AL amyloid shown here, this diagnosis AL cannot be made without a biopsy. There has to be some biopsy of the heart or another organ in order to confirm the diagnosis. If there, however, are no proteins that would suggest AL cardiac amyloid, you can go on to the scanning test I was showing, and if you're positive and you have no genetic cause, the sent-off genotyping, it's negative, you have arrived non-invasively at the diagnosis of wild-type transthyretin cardiac amyloidosis. How do we manage people with this condition? Well, the mainstay of therapy is to keep the patient what we call euvolemic. That means that their amount of water or fluid status in their body is ideal for that particular individual. Amyloid is a disease when you develop heart failure that causes salt avidity, and little amounts of salt in the food can be retained by the body and cause a lot of swelling. So we recommend certain types of diuretics called aldosterone antagonists. The names for these drugs are alprazolam or aldactone or spironolactone. And we recommend what we call loop diuretics, but particularly bioavailable loop diuretics. Those mean diuretics that are well absorbed, even if there's swelling in the body, because just like there can be swelling in your legs, there could be swelling in amyloid in the wall of the intestines, and that will impair the absorption of a particular medicine. So the bioavailable loop diuretics are so-called torsemide. Other name for it is Demodex or bumetanide or Bumex. Calcium channel blockers, which are medications to treat high blood pressure, and digoxin. These are medicines that we strongly recommend patients with ATTR amyloid do not take. Why? Well, calcium channel blockers can lower the blood pressure, slow the heart rate, but they bind very avidly to the amyloid fibrils in the heart because the calcium channel blockers like to bind to spots where there are calcium. And in amyloid, there's a lot of calcium, if you will, in the amyloid fibrils. How do we know that? The pyrophosphate scans I showed you previously are scans that are used to diagnose bone problems, and in bones there are a lot of calcium. So calcium channel blockers are something we avoid utilizing in patients with transthyretin and cardiac amyloid. General medicines I mentioned before that are typically used to treat heart failure, so-called ACE inhibitors or angiotensin converting enzyme inhibitors or angiotensin receptor blockers, ARBs, and beta blockers. Patients usually don't tolerate them and feel worse. I'll show you some data that they may be harmful. Often, toward the latter phases of the condition, blood pressure can be low, not high, and patients may need stockings to raise their blood pressure, prevent the blood from pooling in the legs, and a medicine called midodrine to raise the blood pressure. In our experience, the amyloid not only gets in the heart muscle, so-called the wall of the heart, but it also can get into the electrical wires and cause slow heart rhythms, and about a third of patients need a pacemaker over time. And there's always been a debate about whether or not something called an ICD, an automatic implantable cardiac defibrillator, is needed in patients with amyloid, but most of these patients don't expire from a malignant arrhythmia, and so the role of an ICD is not very high and not very great in these particular patients. So what are the potential therapeutic options for this particular condition? Great to know that you have it, but what could be done about it? And so illustrated in this cartoon are, again, the process of how the disease develops. I don't know if I mentioned, but the transthyretin protein, otherwise also known as prealbumin, is produced in the liver. 99% of the protein is made in the liver. This, again, is the protein that will exist like a four-leaf clover, and as I showed you, it falls apart and forms these amyloid fibrils. So one strategy is to stop the production of the protein. In the remote past, years and years ago, for young individuals who had mutations, that was a liver transplant. But there are drugs that are being developed to essentially silence the transthyretin protein. These drugs have shown some preliminary efficacy in studies for patients who had genetic causes of amyloid, not the wild type form, and whose amyloid predominantly affected the nerves. And so there's a lot of excitement about applying these quote-unquote silencer-like drugs to patients with cardiac amyloid, but those studies have yet to be initiated as far as I know. Then there's the idea of TTR stabilization, that is to prevent the protein from falling apart. In theory, if we prevent the protein from falling apart, it won't continue to progress, and you would stabilize the condition. And there are several drugs in this particular category, but the one that's furthest along is two that are furthest along is a drug tafamidis, otherwise known as Vyndaqel, that is in late-phase clinical trials and will be reporting, we believe, in the next few months about whether or not it's effective for treating TTR cardiac amyloid. And then there's a non-steroidal-like agent called Dolabit or diflunisal that also helps keep the protein together, though one has to be cautious about using non-steroidals, Motrin-like drugs, in patients who are elderly with heart disease. And the final strategy is to get the amyloid out of the organ, and there are several emerging strategies of what we call fibril degradation. These are monoclonal antibodies that may help the body remove amyloid like Pac-Man. So again, TTR stabilization is this idea in which you put a small molecule in between the leaves and you favor the protein staying together as opposed to the protein falling apart. The stabilizers I mentioned, diflunisal, which is a non-steroidal, and tafamidis, a drug analogous to diflunisal that binds in this interface. You can see the drug right in here. Here's the transthyretin protein. It's 4 leaves, and the drug fits in between and kind of at the dimer-dimer interface locks the protein together, prevent it from falling apart. These have not been proven to prolong life or improve the quality of life yet in patients with wild-type cardiac amyloid, but there's a lot of hope for them. As I mentioned, we will know shortly because there's a relatively large for amyloid clinical trial. This is a phase 3, which means if it's successful and meets all its endpoints, there may be a new drug on the market trial. It involved 441 patients who had ATTR cardiac amyloid, both due to the wild type and the mutant form, who either got 80 milligrams of this drug tafamidis, 20 milligrams or placebo, and the trial was 30 months. and we expect to know the results later this year. Again, this drug is not approved in the U.S. for use. The other therapeutic option, again, is TTR suppression, shown over here, going in order of the likelihood of these therapies to come to market. So here is a small interfering piece of RNA, or something called an antisense oligonucleotide. People can develop a drug that is going to block the production of the protein that I mentioned before. These drugs are usually administered by a subcutaneous shot or intravenous injection, and they find their way to the spot in the liver where the protein's being made. They stop the protein from being made, and they block the production of the protein. So your transthyretin level in your bloodstream goes way, way down. If normal is 20, it goes to 2, 3, or 4. There's a 90% suppression. The theory being that with no transthyretin around, you will not have progressive disease. And so the hypothesis behind these small interfering RNAs or antisense oligonucleotides, similar drugs that silence TTR, is that the protein becomes unstable, gets deposited in your heart, and causes the problem. And if you were to block the production of the protein, you would reduce the amount of protein in the bloodstream, you would prevent any damage to the heart, and might even stabilize or potentially recover the damage that has occurred to the heart. And then the final is these amyloid fibril degradation ideas, in which, again, there are monoclonal antibodies being developed in which you could activate your immune system and potentially help extract the amyloid out of the heart, reversing many of the consequences that occur when amyloid deposits in the myocardium. So I hope I've given you a broad overview today about wild-type TTR amyloid. It's clearly more common than we once thought, and it's very important to have an accurate diagnosis prior to any therapeutic interventions. For those of you who have been diagnosed with this particular condition, management involves weighing yourself on a daily basis and trying to maintain your fluid status in an ideal way, almost described as walking on a tightrope, that is adjusting diuretics. It requires healthcare providers, including physicians and allied health professionals, nurse practitioners, PAs, who can be accessible and you can have frequent contact with so that they can intervene. If you gain a little weight, they can reinforce the importance of a low-sodium diet, adjust your diuretics, and try to keep you, God willing, home and safe and out of the hospital. There is a clear need to avoid certain hazardous medicines, and while I think to date I can't tell an individual patient that there is a therapy for this condition, wild-type TTR, that has been unequivocally proven to make people live longer and feel better, there are multiple therapies that are emerging as we have a better understanding of how the condition develops. And so I would strongly recommend that you consider to be seen at an amyloid center and consider enrollment in one of the ongoing clinical trials that will provide you access to a drug earlier than you would get it naturally and may help you and may help the field as well. In rare individuals who are diagnosed with this condition at a relatively early age, I didn't spend a lot of time talking about this, but in very select cases, organ transplantation can be pursued, but that requires a much longer discussion. I thank you all for participating in the webinar today, and I'm happy to answer any questions.
All right, Dr. Maurer, thanks for a tremendous presentation today. And with that, we will move into our Q&A session. As a reminder, text chat located on the right-hand side of your screen. To submit a question, type in your question in the small text box at the bottom. When you're finished, just simply click the send button. Please note that due to time constraints, we may not be able to respond to all of the questions submitted. And at this point, Dr. Maurer, I'll welcome you into the conversation. It looks like we have a good start in a number of questions, so feel free to jump in and begin.
Well, thank you very much. Appreciate everyone taking the time out of your busy schedules to join the webinar, and appreciate all the questions that have been submitted. I'll just read them and comment. Certainly feel free to follow up if I don't address the particular question. So the first is, how can tafamidis be obtained for wild-type TTR cardiac amyloid patients or problems? an excellent question. Tafamidis, as I mentioned, is a transthyretin stabilizer, an oral medicine that can keep the protein together and prevent progression of disease. While you may be aware that tafamidis, its trade name is Vyndaqel, was approved in Europe to treat transthyretin amyloid involving the nerves, it was not approved and has not been approved either in Europe or the U.S. to treat amyloid involving the heart. That's because we don't yet have data that is available to show that the drug is effective in those particular populations. We are excited about the upcoming ATTR-ACT trial, which finished not only enrollment but the last subject just this month. And the sponsor of the trial is vigorously analyzing the data, and so the hope will be that the drug will show efficacy. If it does, then the drug would become ideally available in the United States. All of that is pending, obviously, regulatory approval by the Food and Drug Administration. So unfortunately, the drug is, again, not approved in the U.S. And can't be obtained in the United States in any way to treat cardiac amyloid. Another question we have from someone who has been, it says, completing 3 years on inotersen with Dr. Benson. They ask, do you think this type of product will be successful by itself, or will it need an antibody? Any thoughts on what you think the future treatment strategy may prove to be most effective? So this is an excellent question. Just to backtrack, inotersen is the antisense, one of the silencers I mentioned before. These particular agents have been studied in patients with transthyretin amyloid involving the nerves. There have been 2 completed trials with a silencer and an antisense, inotersen being the antisense. And so those trials, you may have heard about them, have reported and met their primary endpoint, which means they were successful. Both companies who make those particular products are applying for approval in the U.S. and in other countries. The study that Dr. Benson was conducting, that this individual participated in, was a clinical trial. It was a open-label clinical trial, phase 2, to determine whether or not inotersen in patients who had cardiac amyloid would be effective. That is, by giving this medicine a shot in the belly, similar to like insulin once a week, which results in a lower level of transthyretin in the bloodstream, whether that would, be safe, well tolerated in such patients. So I'm happy to hear that this individual's been on the trial for 3 years, and I hope they're doing well. Their broader question is, we've talked about 3 different strategies to treat transthyretin cardiac amyloid: stabilization, silencing, or, if you will, extraction. And they're asking, will one be sufficient? Unfortunately, I don't know the answer to that. I think it's an emerging belief that combination therapy may be something that is useful. You could imagine that a silencer such as inotersen that lowers the prealbumin levels from, let's say, normal of 20 down to 2, so it suppresses the transthyretin production by 90%, would be very helpful because there's no longer protein being produced that can get stuck inside the heart. Having said all that, there is still a residual transthyretin around that may be contributing to some progression of disease, and so a combination, for example, of a silencer with a stabilizer such as tafamidis or diflunisal could be logical. The other question embedded in here was the idea of an antibody. Would an antibody help do something different? And the hope for antibodies is that they can actually extract amyloid from particular tissues that are affected, in this case the heart, and they have great hope for actually reversing organ dysfunction, potentially even greater hope than the other therapies. Just so you know, there are several antibodies that are emerging into early clinical trials. And so I would encourage individuals and their loved ones who are affected by this to, at least in the U.S., search online. There's a website called clinicaltrials.gov. It lists and identifies all ongoing clinical trials throughout the entire country in all different diseases. But you could search the database by amyloid, find ongoing trials and the sites that are conducting them, and certainly explore further whether or not you might be eligible by speaking to people in that particular regard. Let me see. The next question involves the question of epidemiological factors, age, sex. Do they provide any clues to the causes of wild-type TTR amyloid? I think there's an excellent question. Certainly, this is somewhat of a unique disease, even when it's caused by a genetic cause, because it has what we would describe as an age-dependent penetrance, meaning even though you're born with, for example, the mutation, you don't usually develop disease for decades onward. So there's probably something about the aging process. Some have felt that there may be some particular proteins that get exposed, for example, in the heart or in ligaments as we age that may contribute to the deposition of a wild-type transthyretin in the heart. And certainly there's been some hypotheses about gender disparities, because as I mentioned, at most amyloid centers, a vast majority of the patients who are currently diagnosed with wild-type TTR amyloid are males, and so is there something protective in women in this particular regard? These are all, that would lead to potentially a hypothesis about some, hormonal regulation that may be playing a role. So the epidemiological factors do provide us with hypotheses that people are trying to explore, but currently there's no definite link to, age or gender that we can pinpoint. Someone asks, what causes this broadly, and how can it be prevented? And am I at risk as a child from amyloid parent? So again, the cause of this is misfolded proteins, and this particular mechanism is quite rampant in all of medicine. You may be aware that protein misfolding causes not only amyloid, but other diseases such as Alzheimer's, Parkinson's, sickle cell disease. And so medicine has become much more interested in the process of how we make proteins, how they execute their normal function, how they fold correctly, and how we get rid of misfolded proteins, because this is apparently a cause of many age-related diseases. We don't know yet of any ways to quote-unquote prevent this particular condition. While it's certainly more common than we once thought, I would point out it is not very common. So I wouldn't get very worried about it. I would strongly urge people to continue to live healthy lives, diet, exercise, and so forth, though there's little evidence that any exercise or dietary interventions can ameliorate any risk at this point of developing this. And the last question about, again, wild-type TTR, as far as we know, is not a genetic condition. And so loved ones, children of an affected parent, for example, are not at increased risk of developing transthyretin wild-type amyloid. We have a question from someone who notes they've been taking a doxycycline for the past 22 months, and they found it to be helpful, especially with their breathing and their walking. And they asked, do we have any information on this treatment? It's an excellent question. Doxycycline is an antibiotic. It's been shown in some seminal work by colleagues in animal models of amyloid to help in disrupt the formation of amyloid fibrils. And so doxycycline has been hypothesized from these animal experiments to potentially be a useful agent in preventing amyloid, if you will, from continuing to form and helping degrade it. Unfortunately, we don't have any real high-quality, what we would call in medicine, clinical trial data in this particular regard. There have been some small open-label studies in which amyloid experts have provided doxycycline, usually in combination with something called a bile salt. In Europe, it's called TUDCA, and that can, in combination, again, from these animal models, help degrade amyloid. We have given doxycycline to some of our patients. Again, the chronic use of doxycycline as an antibiotic is associated with certain side effects, not necessarily intolerable, but you should be aware of, and that is a percentage of patients will complain of abdominal discomfort, abdominal pain after starting doxycycline. It also is an antibiotic that causes a significant sun sensitivity, and so you have to be very careful when you go out in the sun and make sure that you're careful not to have too much sun exposure. Someone asked, what is the mechanism for cardiac dysfunction with TTR amyloid? A simple description doesn't really explain it. So again, I'll try. The primary process here is one in which misfolded proteins deposit in the myocardium. They make the heart thickened and leathery. The heart, as a pump, needs to not only pump the blood, but also needs to fill. It has to have a certain capacity or capacitance. So when I'm trying to explain this to patients, I usually give the analogy like a balloon. If I were to provide you or your loved ones with a balloon made of rubber and ask you to blow it up, you would exert a certain amount of pressure, you'd push, and you would fill the balloon up. If, however, you gave me a balloon and the balloon was made of leather, I would have a significant difficulty trying to blow up the balloon, and as a result, would have, the cardiac function would be markedly impaired. So for a heart to work as a pump, it not only has to fill with blood, but it needs to expand. And in amyloid, the heart has trouble expanding. Someone asked how long can people live with this? They note that their father is 69 and he can't run or jog. So that's a common question. Our ability, I would say, to predict, survival in an individual patient is quite poor. There have been systems that have been developed, particularly by colleagues, for example, in the National Amyloid Center in London and at the Mayo Clinic, that can use certain blood tests to identify, if you will, the stage of the disease, how far along the condition is into early, middle, and late, and those can provide some degree of prognostic information with regards to one's survival. But for an individual patient, it's really hard to identify exactly how long someone's going to live with this. In general, in the past, when patients were diagnosed early, the literature would say that survival was somewhere in the range of 5 to 10 years after an initial diagnosis. So again, that's highly dependent upon the stage of the disease. Someone asked, can diet changes or other low sodium impact management and treatment? I think this is incredibly important, and hopefully I emphasize this in the talk today. Cardiac amyloid is a condition associated with marked salt avidity. When you eat salty foods, your body tends to retain the salt, and along with it, the water. And as a result, you can get swollen, you can gain a considerable amount of weight when you, for example, have some, if you will, dietary indiscretion, eat out at a restaurant or a family party or so forth, and gain a significant amount of weight. When you become very swollen, it's almost like someone put a backpack on you and added in liters and liters of water. Trying to function and move around with 4 or 5 kilograms of extra water in your body is obviously very difficult. It makes patients feel fatigued and tired and short of breath. And so there's no doubt that managing the condition with low sodium intake, judicious but appropriate use of diuretics, careful attention to one's weight and fluid status is one of the mainstays of managing this particular problem, and it can't be overemphasized. Someone asked about siRNA, and if it crosses, they wrote the BBB, I assume they mean the blood-brain barrier. Can it create a problem as TTR pool in the brain is locally produced and is responsible of 90% of the T4 binding? Somewhat of a complicated question, but drugs variably do cross the blood-brain barrier. It's not entirely clear that siRNAs will do that. The question does require some further explanation. While I said 99% of the transthyretin produced in the body is produced in the liver, there is small portions of transthyretin that are produced in the choroid plexus and in the eye. in individuals not with wild-type TTR that we know of, but in individuals with mutations, the production locally in the brain and the eye can cause certain clinical manifestations with regard to TTR amyloid, and the construct of how to get drugs into those locations, i.e. through the blood-brain barrier in order to ameliorate some of the eye or other findings, is an area of active investigation amongst the pharmaceutical companies. Next question someone asked, did you say that tafamidis was not currently an upcoming drug for wild type? And that is incorrect. I apologize if I said it in a fashion that wasn't clear. So the current conducted clinical trial that has been completed, the so-called ATTR-ACT trial, involves 441 patients, approximately 70% of whom had wild-type transthyretin amyloidosis. About 30% of the patients had mutant. If that trial is successful, and we'll know shortly, then tafamidis would be hopefully a labeled, clinically available drug for treating wild-type TTR amyloid. So there's a lot of hope on the horizon for many therapies, but the one that's furthest along for regulatory approval is tafamidis. So it is available, it is being tested or evaluated, not available for a wild-type TTR amyloid. Someone asked, importantly, how important is it to diagnose the disease in time? If this isn't very important, how often do you need to be examined to determine if amyloids have started to build up, and this is for the familial form? It's an excellent question. So there are individuals who have obviously are genetic carriers of mutations that can cause TTR amyloid. As I mentioned, there are many mutations, believe it or not, over 100 mutations in the TTR protein, and they cause different phenotypes. Phenotype meaning different clinical manifestations, some predominantly a neuropathy, some predominantly a cardiac manifestation, and some a mixed phenotype in which the heart and the nerves are affected. Various mutations do penetrate or show up typically at a certain age. For example, the VAL122 ILE mutation, which is the common mutation that affects African Americans in the United States, typically shows up after the age of 60. It typically shows up later in women than in men. And so based on the particular mutation, certainly your family history, if someone in your family was affected, a provider, typically an amyloid expert, could begin to, and I would recommend begin to screen or try to identify the disease as early as possible. In patients that we're caring for at our center who have familial amyloid cardiomyopathy, or I should say are carriers of mutations that could cause that, we typically perform blood tests, clinical exams, pyrophosphate scans, as I mentioned, trying to identify the condition early in its course. And at least to date, there haven't been available agents besides diflunisal, so we've been prescribing for such patients who have clinical manifestations of disease, God forbid symptoms, abnormal echoes, abnormalities on EKG, or even if they have none of those but have an abnormal pyrophosphate scan, we have been instituting, after a discussion, therapy with diflunisal or Dolabid. Diflunisal, as I mentioned, is a non-steroidal, so you have to be very cautious about administering it in individuals who have who are at high risk for adverse events. Non-steroidals given chronically, Motrin as an example, can cause fluid retention, which we talked about is already a problem in amyloid, can cause kidney dysfunction. They can cause bleeding, both gastrointestinal or, God forbid, intracerebral inside the brain bleeding. And so these drugs have to be used cautiously and carefully, and they're usually not well tolerated by patients who have advanced cardiac amyloid. Someone asked nowadays how many trials exist for a TTR cardiac amyloid and where. It's an excellent question. I'm not sure I know of every trial that's being conducted in the United States. The trials I think that this person may be referring to, these are trials of novel medications. Currently at our center, we don't have any active clinical trials for wild-type TTR amyloid. We do know of several trials that are in the planning phases of novel stabilizers or newer ones in addition to, for example, tafamidis. They should be starting, I believe, later this year. As well, there are hopes that the excellent results seen with transthyretin silencers, those are the siRNAs, and the oligonucleotides or antisense, they will be entering, we hope, into clinical trials later this year or as soon as possible. We're also at our center in discussions with a company who's working on a TTR antibody that's specific to try to extract amyloid. Unfortunately, at our center, at least today, if someone came, I do not have an active clinical trial, but a lot going on. And this changes from center to center and quite radically. That's why I mentioned trying to set up a system in which you are in contact with either the Amyloidosis Foundation, which has been outstanding at providing the fact that new trials are opening, and then you can contact the particular sites to find out if you're eligible, and also setting up alerts for yourself on clinicaltrials.gov. Someone asked, is there a clinical trial proposed or underway for cardiac amyloid deposits on the heart? And again, there are several trials that I mentioned. The hope is that the silencers that we described before will begin to be leveraged by the pharmaceutical companies for wild-type TTR amyloid. They've certainly shown an interest in doing that, and also, as I mentioned, there are particular antibodies that are specific for TTR that are being developed, and those trials are expected to begin recruitment later this year. Someone asked about the success of LVADs for treatment with wild-type TTR patients. So LVAD stands for a left ventricular assist device. These are artificial heart pumps that can be placed surgically. It's a very, very big operation. They're usually utilized for people who have a different form of heart failure. That is what we call systolic heart failure, or heart failure with a reduced ejection fraction. Surgeries are logical in patients who have very enlarged hearts with relatively thin walls, because the pump itself has a large, if you will, cannula. That is a tube that gets placed in the tip of the heart to take the blood out and provide it to a pump that helps propel the blood around the body and augment the function of the heart. Obviously, placing a pump inside the body and the cannula in a heart that's small in its cavity size and thick-walled is difficult, and it's been demonstrated by several centers that the tolerance of patients with wild-type TTR amyloid for LVADs has not yielded great results. And so never want to say no for an individual patient, but it's not something that is typically done, in part because of the different physiology. Several other questions I see here, again, about doxycycline, and as I mentioned before, there's very little clinical trial evidence, which is what clinicians kind of rely upon. Again, just so you understand clinical trial development, phase 1 of a clinical trial is testing a drug to make sure that you figure out that it's safe and you know the right dose. Phase 2 usually involves what we call an open label study, further exploring the safety of a drug in a larger population at the dose that you picked. Phase 3 are usually randomized in pharmaceutical trials, clinical trials that are blinded, so the investigator and the patient doesn't know what they're getting. And those trials, phase 3, usually lead to regulatory, God willing, approval if the drug is successful. Phase 4 are studies that are called post-marketing studies, in which the drug is already on the market, and individuals are, testing, and pharmaceutical companies are determining the efficacy of their drug in a real-world population. Doxycycline, while having laboratory-based data in animal models, has not ever been subjected, that I know of, to a randomized clinical trial, and so it's being applied. It is obviously got some theoretic benefits, and it's a drug that's available. You can get it from the pharmacy, again, with the caveats I mentioned before about sun sensitivity and abdominal discomfort, but I don't think we have enough evidence to know whether or not it is terribly effective. Someone asked about stem cells and whether or not they've been tested against amyloidosis, this is an excellent question. Obviously, there's a large amount of hope and promise with regard to stem cell therapy. That is usually applied in heart failure to patients whose heart muscle has died after, for example, a myocardial infarction or a heart attack, to regenerate or regrow heart muscle. I do not know of any clinical trials that are being tested with regard to stem cells for amyloid. And if you think about the, if you will, biology of the disease, it may not make as much sense because the problem here is not one in which the heart muscle cells are insufficient. They're being crowded, damaged by the fibrils that are being stuck around the muscle cells in the, what we call the interstitium. Stem cells are not something that I'm aware of are being applied for cardiac amyloid. Someone asked about Prothena made an antibody against TTR. Do you think it will be effective, or have any plans to study it? I know it is being studied for cardiac AL. So this is a great question. Prothena is a company that specializes in developing antibodies for amyloidosis. They do have an antibody that is specific for AL, or light chain amyloid. That was not the focus of our discussion today. That particular antibody, called NEOD-001, has gotten to phase 3. There's a relatively large trial called VITAL that has finished enrollment, and results are expected, sometime next year, to determine whether or not that antibody would be effective for people with AL, or light chain cardiac amyloid. Prothena has made an antibody. I believe it's abbreviated PRX004 for the name, in case you want to look it up, that is specific for transthyretin amyloid. Obviously, different proteins causing different amyloid have different structures, and we think would require different antibodies to be effective. And we are one of the sites that has been selected to treat, or administer, I should say, this particular antibody as part of essentially a phase 1 study to figure out, is it safe, and is there a dose that could be decided upon to move into future studies. So while we remain quite hopeful, it is, I think, far away from being approved by regulatory authorities and being on the market. Someone asked, did I say there's no cure currently available in the USA at this time? Again, there's no specific therapy that has been shown to make people live longer or feel better with wild-type TTR amyloid that is currently on the market in the U.S. I understand someone wrote that Pfizer has submitted to the FDA their drug patisiran. The drug patisiran is actually made by a company called Alnylam. It is an intravenous medicine that is a silencer. It's a small interfering RNA, the pictures I showed before. And that drug, it is correct, is being submitted for consideration both in the United States and Europe. The drug is being reviewed, and you can find out the details probably online, but the latest I had heard was that the FDA is going to consider this product and its potential approval over the summer. Again, unfortunately, the studies that have been done to date have been in individuals who are younger than those with wild-type TTR amyloid, and in those who have amyloid deposited in the nerves, not specifically in the heart. We don't know that the drugs would work in all of these populations. Makes sense that they would, but those studies need to be conducted prior to regulatory approval, and so there's still studies to be done. Someone asked, what is the difference between tafamidis and diflunisal? Well, tafamidis is an analog of diflunisal. It's chemically similar to diflunisal, but it does not have any non-steroidal properties that we're aware of. So many of the side effects that we get concerned about with diflunisal, that is fluid retention, risk of bleeding, renal dysfunction, in theory, were not seen, at least to date, and we don't expect to be seen with tafamidis. Whether one agent is truthfully more effective than the other is unknown and hasn't been well evaluated. Someone else asks an excellent question: why is tafamidis so expensive in Europe? And I don't know. I think that's a good question for the pharmaceutical companies. Obviously, the difference between tafamidis and diflunisal, as mentioned before, chemically, are important, but if they both work reasonably well, clearly the cost of diflunisal is much, much cheaper, on the orders of a few pennies a day compared to the cost of tafamidis, and that clearly impacts on people's ability to get access to drugs, which is a huge problem in the United States. Someone asks a question about of the upcoming treatments for ATTR wild type, do you have any feelings on which methods seem to be most effective or could be most effective? Truthfully, I have hope for all of these therapies. I think they all make great biological sense. We've, based on the expert knowledge of fantastic scientists, have learned a lot about how this disease develops. As I tried to show you today, how the protein misfolds, falls apart, gets deposited, and it's really a credit to the basic scientists who had figured out the mechanism of these diseases. Whether, and my hope is that they will all be effective. I think the question is in part getting to the idea of, well, is one therapy going to be more effective than another? I, along with I'm sure many people on this call, remain frustrated by how long it takes to develop these particular products, but the studies that are done are usually comparing one drug versus a sugar pill or placebo. Rarely, even in much more common diseases, do we compare one drug versus another. And so I just don't know whether or not one therapy would be more or less effective than another. There's a question about how prevalent is screening with, I guess, DBT or PYP. Is it only at amyloid centers, and do we expect it to increase? So there's a great question. PYP scanning is not very technically sophisticated thing to do. It can be done, and my understanding from providers around the country is it is being done at many, many places throughout the country, including in private practitioners' offices. Pyrophosphate, PYP is the abbreviation, is an isotope that has been around for more than 50 years. It's very inexpensive. A dose costs well under $50, and cardiologists and nuclear medicine experts have access to cameras and scans that can do this test. If you're interested in learning more, there is, or your provider is, the American Society of Nuclear Cardiology, that is a national organization, has developed on their website what's called a practice point that could inform a provider such as a cardiologist on how to do this test, and how to set up the camera, how to administer it, interpret it. At our center, the test involves the placement of an IV, the administration of the technetium pyrophosphate, which hasn't in more than 500 scans caused any problems. The amount of radiation, because it's a radioisotope, is very minimal. It's less than or equal to a mammogram, and patients receive the isotope. They then wait around for an hour, allow it to circulate throughout the body, and they're placed under the camera. and it takes about 8 minutes of time for the camera to acquire the pictures. And so I do expect this test to increase. I think it has incredible value and has changed the field quite a bit, allowing us to diagnose the disease without a biopsy. We'll continue onward with some more questions. I do note that there are lots of questions here, and we may not get to all of them, which I apologize about. Someone asked who would be the best provider of frequent fluid buildup to monitor, cardiologist versus primary care. I don't know if there's a better provider. This is somewhat individualized. I think you certainly want, as I mentioned, a provider who you can contact and have access to for frequent dialogues and communications. At our center, we have wonderful nurse practitioners who help us in monitoring patients. Patients who record their weight every day, note some, God forbid, increase in symptoms and fluid retention are able to contact us. We call them back within, certainly the day, advising them what to do with regard to their diuretics. I would point out, if you're adjusting your diuretics frequently and consistently, it may be very important to also have a monitoring of your kidney function and your electrolytes, because diuretics tend to cause a loss of potassium in the urine, which could have clinical consequences. But the short answer is whichever provider is more accessible per se and feels more comfortable. Someone asked which therapy has a better effect for a 54-year-old patient. Again, as I mentioned, I don't think we know which therapy is better than another. I would just note that while I mentioned that this disease is one that occurs with advancing age, we are beginning to recognize that this condition is not only occurring in people over the age of 65 or 70 years of age. And as this question points out, there are individuals who have this problem much earlier than we ever thought, and probably it is, well, we know it's slowly developing and indolent, and early diagnosis will be important. Someone asked, is a filtration system not also able to help? I've heard that there's a filtration system being developed for Alzheimer's amyloids. I don't know of any filtering system that can remove these proteins and keep them removed. Unfortunately, the body makes these proteins all the time, and I don't know of any system that would filter or remove them, though that is a logical thought and approach. In general, the analogous idea is the idea of silencing or stopping the production with the medicines I mentioned. Someone asked that their understanding of the data is that wild-type TTR is much more prevalent than either AL or familial. Why are these clinical trials not using wild-type patients? I think that's an excellent question. My own sense is that the pharmaceutical company is, a little bit afraid to develop drugs in older adults because of the potential risks of developing new therapies in older adults with altered liver and renal metabolism. I think this question points out that many pharmaceutical companies do usually develop drugs in younger individuals where my sense is the risks to them are less. I hope that's something as a individual who focuses on emerging therapies for older adults that we could tackle and encourage them. Certainly, as the question indicates, there's a much larger market potentially for wild-type TTR amyloid, which might motivate them. We're coming close to the end of the hour. Someone asked about green tea extract, an excellent question. So green tea and the protein in green tea called EGCG has been shown in laboratory studies to stabilize the transthyretin protein. So it works as a stabilizer. There are, again, some open-label studies that have been published, particularly by colleagues in Germany at Heidelberg University, in which green tea, typically at a dose of about 750 milligrams a day, was administered to patients. These were open-label studies, so they were not randomized. Everyone knew what they were getting. And over the year's time, they seemed to have no change in cardiac structure or function as determined by a sophisticated test called an MRI, which I showed you. Again, as you can hear, I think I'm trying to indicate we just don't have high-quality data that's randomized and blinded to really know. Certainly, it's something that is relatively low risk, and you can talk to your provider about.
Dr. Maurer, it would appear we're just about out of time. You may want to address one more question quickly, and then any concluding thoughts you have.
Yeah, well, there's many questions here. I think I'd just like to say that, myself and I think many of the providers in the amyloid community are happy to serve as a resource, try to address questions that arise. It is and remains to be a privilege to take care of patients with cardiac amyloid. They're by far and away a wonderful group of individuals, and I think I would like to leave everyone with a sense of hope on the horizon, that there's a wonderful understanding that's being developed regarding the biology of the disease, and we are on the cutting edge of developing some new and emerging therapies. And so I thank you for taking time out of your schedules and for participating in today's webinar, and I hope it was useful.
Thank you for a tremendous presentation and your thoughtful responses to the questions you were able to address. On behalf of the Amyloidosis Foundation, we would like to thank you for your participation in today's event. Post-event survey will appear requesting your feedback. If you would take a moment to complete this survey, as it will help the Amyloidosis Foundation plan future web events. This will conclude our program for today. Thanks, everyone, and have a great rest of your day.